I am Dr. Trinidad, and I'll be your moderator for this evening. And we have on our panel two very distinguished practitioners. On the far left is Dr. Dilip Dan, a consultant surgeon who's well known for his work on bariatric surgery. And next to him is Dr. Faisal Daniel, who is an endoscopist and who is well versed in colorectal cancer and screening for it. So, who's going to start? Dr. Dan or Faisal?
How about Stacy?
Okay, I'm going to ask Stacy to start. She is Secretary of our Medical Association, Trinidad and Tobago Medical Association. I'm the PRO, so I'm going to call on her to introduce this session to you. Stacy?
Thank you, doctors, and to all of you who've come out today. I'm a primary care physician. I work on the wharf. I'm a general physician who works on the wharf, and I also do a little bit of work in hospital in the oncology clinic. And I think one of the things I've noticed is that a lot of our colorectal cancer patients are diagnosed very, very late. And I do something called palliative care, and I find that a lot of them come to us in stage 4. So there are 4 stages of cancer, and very often they're diagnosed at stage 4. So one of the reasons I think we wanted to do this, and just for the public knowledge, and even for me as a primary care physician, as a GP, I wanted to ask, what is the best way for me to maybe encourage some of my patients to get screened for colorectal cancer so that I can help them, if they're going to have this cancer, diagnose it early enough so that we might actually be able to help them.
Right, so a pleasure to be here this afternoon. We want to talk about colorectal cancer. So before we talk about screening, I would think, to make it interactive, any questions from the audience about colorectal cancer? Anything you don't know and you want to ask? No? Okay. Yes, sir. Trinidad and Tobago is very common in terms of colorectal cancer. In fact, it's the #1 cancer that affects both men and women. And from the international statistics out of the UN, it's GloboCan they call it, they predict by 2015, 1 person will be diagnosed with colorectal cancer a day in Trinidad locally, more so men. So from what we know at the outset, it's a problem locally, it's high risk, and like I said, far too many people being diagnosed late. So there's several things we can do to make things better over time. And the most important part is letting you all know what to look out for as far as symptoms goes. But the thing is, with colorectal cancer, you don't necessarily want to wait for symptoms, because one of the risk factors of colorectal cancer is living longer. The longer you live, having had a good life, that alone puts you at risk of colorectal cancer. And certainly if you're going to live into 80s and 80s, I would say late 70s and 80s, getting screened once you cross 50 into the 60s certainly makes sense for the long term. Not for now benefit, but for a long-term benefit. And, but I don't want to get into screening just yet. I want to be clear that you all are comfortable with what colorectal cancer is and what the symptoms are. And at this point, I'll introduce you to Dr. Dan, who certainly sees a lot of that on a weekly, daily basis. Perhaps far too much.
Thank you very much. Just to make it easy, the colon is the large bowel, the rectum is the lower end of the bowel, and these tumors, they're cancers, and they all start with polyps. Or most of them, they start as polyps. And polyps are little growths that are benign. And the aim is to identify these polyps before they go on to become cancers. Because when they become cancers, as Dr. Chamley says, sometimes they present too late, and there isn't much that one can do to help those patients. However, if you can identify the polyps early, then those patients generally are curable, and they can be monitored for the early development of cancer, which is still curable. But as we go on to the stage for cancers, we go to a point where we can only do what is termed palliative care and just help to relieve their pain, their obstruction, and some of their symptoms. So the aim in general, because the incidence is so prevalent, is to try to identify these tumors before they become cancers. And you know, we talk about the majority of cancers happening after the age of 50, maybe about 70, 80, maybe up to 90%. However, we are seeing colorectal cancers in patients who are as young as 21 years old. I mean, I've seen a 14-year-old and now a 21-year-old last year. So, and this is not with any pre-existing risk factor. These are patients who have absolutely no risk and they just develop colon cancer. So it is becoming relevant for each and every person to get into this battle, to identify these tumors early so that we can, you know, survive longer because of it.
You know, the thing is, I'm going to ask you two or three questions. The first thing, how many of you had your PSA tested, the men? You've had your PSA testing done? Right, nearly all the men here. Women, ladies, I know you'll examine your breast. How many of you all have had mammograms done? Right, good. Now what you want to do is to bring things to the level where people know that the colorectal cancer is a problem and we are at risk and there are things we can do about it. So what we would like ideally is people going to the doctor and say, Doc, you know, I am past 50 now and I don't have any family history of cancer and stuff, but I want to get checked for colon cancer. And I hear I have a stool test where you can check the stool for blood that you cannot see. That's a simple thing, which is cheaper than a PSA, cheaper than a mammogram. All you need is anybody capable of a bowel motion can do that test, and that test probably is less than $200 and is already available in the labs. So that's a simple thing that you all can do. So that's only the start of it. Testing your stool for blood. Simple test, right? So we want people to know that that test is available, that they can do it, and it can make a difference. Okay? So that's the first thing. The second thing I would like you all to know is that rectal bleeding is very important. When you do see blood, that is always an important symptom. If you cough blood, if you sneeze blood, if you vomit blood, those are always important signs, right? Now, when you have rectal bleeding and you see blood, regardless of how little it is important. Hemorrhoids is the most common cause of bleeding by far, probably 70–80%. Most common, but it is the least important cause. We're not too worried about hemorrhoids. Anybody walking on two legs, having babies, doing work, could have hemorrhoids, piles, whatever you want to call it. The important thing to know is, and we've all seen it, is that most of the colorectal cancers that we've seen, and I would go as far as saying 75% of them, get delayed late because people thought it was hemorrhoids. They have bleeding, they have some issue down there, they think it's piles. And to make things a little worse, they think it's hemorrhoids and the doctors think it's hemorrhoids too. And so, yeah, try this cream. So we want to bring things to the point where people know that I am 50, I have no problems, my doctor checked me for diabetes, cholesterol, my blood pressure, all those things, let them check my stool for blood. Beyond that, if I have any bleeding, be as little as it may be, that I need a scope to look and see where that blood coming from, to make sure it's not a cancer, it's not a polyp, or anything else. So that's what we want people to be within the next year and so on, increasingly. Any questions?
Faisal, can you tell them about FIT?
FIT, right.
Which is an easy thing to remember.
Right, so we want people to get fit at 50. FIT is the stool test for blood. The fancy scientific name is the fecal, as in stool, immunochemical. So it's a special antigen antibody immune reaction. Like, you know, when you give vaccines, is that kind of reaction within the body when an antibody picks up the blood in the stool. So it's a fecal immunochemical test, the FIT. And that test has been around for the last 10 years. And it's been around locally for probably about 10 years. But when I talk to lab people, they say, well, nobody really do that test much because doctors are not ordering that test and people don't know that it's relevant to them. So the first point is, no problems, you're good, all is well, get fit. We know you're fit, we want to prove it. Get your stools checked.
And I think it's specific for blood from the gut mucosa.
Yes.
Is that right?
Yes.
Yeah.
Well, because it's an immune reaction thing, it is better than the old time test. The older test was called guaiac, and they call it FOBT, right? That's older, and it's better because with that old-time test, which is still around and very cheap, you couldn't eat red meats, you couldn't take certain medications, you had to have 3 bowel motions over 3 days, so it is very laborious. And most times when I see a positive test in that, I say, well, I don't believe it. If it's positive or negative, I don't believe it either which way. But I would be obliged to do something because it is either positive or negative. So I mean, I don't know if Dilip felt any different about the FOBT when he sees the result.
Yeah, well, I think the general consensus is that the FOBT testing has been essentially too laborious and the yield has been too low to make it significant enough, and that's why the whole FOBT thing has kind of failed. But now with this FIT testing, it is much easier to do, less difficult for the patient, actually quite simple to do, and also has a very good sensitivity. So in other words, we pickup rate is actually up to 90%.
Yeah.
And so that is extremely good. Now, there are other tests that we'll get to, but this one is a basic, cheap screening tool that costs nothing, has no harm, and gives a fairly good outcome. So it is very worthwhile as a screening tool. And you know, it should work, and it's hopefully it is not available in the public sector, I think, as yet, but hopefully soon. But it's cheap. It is $200 or less, and that I think is affordable by most.
Certainly, if you spend $200 once a year,
Of course.
that's
once a year.
good investment,
Yeah.
isn't it?
Yeah, of course. And the way I see it is, okay, the bottom line is you have a bowel motion, right? I think you're having a birthday or something. I think it'll be good. A frame of mind to set it in would be to look, go and have a good dinner, have a good meal, have a good bowel motion, get it tested, wake up in the morning, have a cup of coffee, feel nice, do the second sample. You think of it in that framework. You know,
Yes,
it can
sir.
make a difference. Yes, sir.
Question. How and why
Yes.
do people develop polyps?
Well, that's a good question. You know, Trinidad and Tobago, look at, we are either out of Africa, out of India, out of Asia, China, right? The subcontinent. And when you look at those countries, traditionally, they have low rates of colorectal cancer, right? But people who live the Western style of living, like the Americans, the Europeans, we have a certain brand of cancers that come with living like that. Breast cancer, prostate cancer, lung cancer, and colon cancer. So that more than anything else, it is an environmental influence of how we're eating, how we live, how we're living longer. In the subcontinent, be it Africa or Asia, for a long time people weren't going much past 40. So the risk of colon cancer would be low. Also how they would have eaten lots of vegetables, a lot of ground provisions. That's good, that is good quality food, where the risk for colorectal cancer is a lot less. But we live in the Western world, we eat plenty, we live plenty. The part of the price that we pay for living that kind of life is colon cancer, together with breast, prostate, and lung. And there is genetics, yes, but it's more the environment acting on the genes, the two combining. Because when you have like strong family histories of colorectal cancer and it's passed in the genes, that's still really less than 5%, 10%. 10% is plenty. So it's mostly the environmental factors, how we live. Yes?
Are there any markers you can have in the blood? Markers?
Well, that's a good test. I mean, that's a good question. There is a very good blood test that we use in colorectal cancer, but that's when you've been diagnosed with cancer and we're following you up through chemotherapy, radiation, CT scans over time. We have all seen many patients with colorectal cancer who have normal blood. I'm not going to call the name because I don't want people to have that name in their head. You know what that blood test is. I'm not calling it by name. But we have seen many people with colorectal cancer, early stage, with normal blood tests.
Even late stage,
Yes.
because not all the tumors produce this antigen, and as such, it is not useful as a screening tool because we will miss significant amounts of tumors. And what we are really trying to do is to pick up polyps as well, not just cancers, because if we start looking for only cancers, then we miss the polyps, and then it's a little late already. So I think the aim is really to get at the precursor to the cancer, which is the polyp. And that's why the screening is much better at that level rather than going for the tumor marker itself. And the tumor marker has to be reserved for the tumor once we found it
You've
and
diagnosed
diagnosed it.
I have one more question, it's a little more medical. Would diverticular have the same risk as polyps for developing cancer?
No, diverticular disease has absolutely no risk factor for developing colon cancer.
The thing is, too, with cancers may not bleed much at a time. It may bleed a little bit, and people always say, "Oh, doctor, all right, man, the bleeding's it's settled." Cancers don't bleed much. Command your attention. It may drip, drip, drip. And the thing is, the colon, like Dylan said in the beginning, the colon is a muscular tube, but it could swell up like a balloon. So you could have something the size of your hand, like an apple size, a pump stay size, chenette size, on the right side by the appendix growing and growing and growing and weeping blood, and you'll never know. You'd never know unless you test stool blood or go looking for it via colonoscopy. So things are growing, you don't know. When you get symptoms, when you read textbooks, the classical symptoms of colorectal cancer are rectal bleeding, change in bowel habit, weight loss, low blood counts. If you wait for things to sound like a colon cancer before you go for colonoscopy, well, you've missed the boat. At that stage, when people have been diagnosed, they're asking, "So doc, what to eat now?" You know, and it's a hard question to answer because I say, well, it will not make a difference what you do now. So, right, short of surgical treatment, right? So we don't want people to go for colonoscopy when it sounds like they really need one. Prevention is better than cure, and the biggest part of that is you, the people here, having information to close the gap.
Very price of color.
So the gentleman in the back asked if we could use the mic for questions because they're taking this. I'm just going to give you the mic. How's that? So you want to get up.
Yes.
Price rate.
Yes, you want the British price in pounds, the US price in US dollars, the euro price, the TT price? All right, that's a very good question. Colonoscopy is expensive on the grand scheme of things. A colonoscopy on average, be it screening or diagnostic, will cost you anywhere between $3,000 to $4,500, depending how that is TT. Now, I've also had people who said, okay, no, I don't want to do that, they're going away to do it. They go to the States and it costs them $3,000 US to do it.
I guess that's why we trying to talk about the fit test because it's a start and it's less than $200.
Yeah.
And as physicians, we intend to advocate to try and get it in the public health sector, which is where it becomes free. So we're working on that. And that's what part of this is about, is that if we're all chatting about it and we're all asking for it, somebody in the decision-making chair might say, oh, maybe we should get it in the health sector.
Sorry? Presently, they do colonoscopy, but usually it's for people who have problems at present. We have very few people. We don't have all the machinery working every day of the week, Monday to Friday, 8 to 4, throughout. So with that constraint one, and people having problems,
And nor do we have enough colonoscopists,
Yes.
people to do them, or the time to do it. So it's a big challenge to offer colonoscopy as a screen. Now, it is a very good tool, and it is recommended. If you can do one every 10 years, that's perfect. However, because of the constraints of cost, as you realize the difference in the disparity in the cost, and the availability of one in public sector, for one who cannot afford the fit testing yearly, offers a safe yet a good approach to the problem.
Yeah, because you can pick up the cancer before you have symptoms.
Yeah.
That's important. Yes, sir?
Yes, if you do have polyps, that would lead to colorectal.
Yes.
Can, yes. Not all polyps turn into cancer. Not all cancers come from polyps. But if you go looking for polyps, find them, take it out, over time, the number of cancers, colorectal cancer you're seeing will drop, a number of people dying of colon cancer will drop. And this is what we see out of the US survey, where because in America, the screening test is colonoscopy, which is paid for by Medicare and in the insurance. And with their liberal use of colonoscopy, their colorectal cancer rates are falling. In contrast to the other countries where they're just kind of keeping things level. So the colonoscopy does make a difference over the long term, once it's available.
And if you have polyps, what your diet should be to assist the situation.
Well, diet can only help so far.
Well, the diet has to be low fat, high fiber diet. That is what we would like. It doesn't necessarily prevent new polyps from forming, but it certainly would maintain a healthy colon. And there's some studies that suggest maybe some extra calcium and vitamin D as well. So calcium and vitamin D. So those are the supplements that would somehow help with the colon health care. But I just want to emphasize that the colon cleansers, these are not really recommended, and they can often do more harm. So I know that's probably your next question.
Well, let me give you an interesting story.
Yes.
I spend my working week looking inside colons, looking at the inside of these things. And I can categorically tell you that I cannot look at a colon and tell you this belongs to an 80-year-old man or this belongs to a 26-year-old person. The colon is remarkably durable. The only thing that could give me a clue that this colon belongs to an older person is if they have the pockets, the divertically that you're asking for, which tells me that the colon is built to do what it does. It does not need cleaning. With stomach is a different story. I could look in his stomach and say, look, this person real old, this person young. I could do that. But with the colon, I can't look and say this belongs to an old person. Because it is durable, it is built to do what it does. Colon cleansing is a waste of time. It's a very easy thing to sell. It's easy to say, boy, that thing needs cleaning, you have to wash it out. Very easy thing to sell. And people do it, they feel good, they like it. I heard that Princess Diana like to do colon cleansers. So it's something people do and they enjoy. But it takes you nowhere closer to the truth, especially if you have a problem. In fact, colonoscopy, I tell people, colonoscopy is effectively a colon cleanser with the camera. You can actually look and see. And that makes all the difference in the world. So don't be fooled by that. Yes?
Faisal, while we're on polyps,
Yes.
can you tell the audience, if you remove the polyp, it's negative for cancer,
Yes.
how soon after you need the next colonoscopy? What is the
Right.
interval?
Well, the whole point of removing polyps is to prevent cancer. So with prevention in mind, if I scoped everybody in this room, and there were those of you who had no polyps, no family history, nothing, you don't need to get a scope for another 10 years. If you had one polyp, which was fairly big in size, and depending on the type, I might say, well, let me see you in 1 year. But then I could, and once you are clear, I could then stretch it out to 5. If you had 1 or 2 little polyps, 5 years. If you had like 5 or 6, 10 polyps, I would take it out, and depending on the type, I might say, okay, maybe 1 year. So it depends on number, type, and size of polyps. And you would then be seen at 1-year intervals, 3-year intervals, 5-year intervals. And every time you're scoped, you then reassess. So like today, I did a young girl who's 26 years old who had an 8-centimeter polyp taken out a year ago. It was removed, so I said, let's check again. So today I scoped out about 15 months after her last scope. And she had another polyp, which was just about 1.5 centimeters. So it was behind the fold. It may have been there when I scoped the first time, but it was smaller. So I was hoping to tell her today that I could see her in 5 years. But having found that polyp and taken it out, I would say, okay, I'll see you in 1 year again. If in a year's time I go there and I see no polyps, I might say, okay, let me see you in 5 years. So it's that kind of reassessment. It's a dynamic thing. It changes as we go along, depending on what we find. And that's the whole point of protection. So at first, you screen this amount, you find this amount with a problem, and that amount you follow through. Yes?
I was going to ask the same question that Dr. Trinidad asked.
Yes.
Thanks for that answer. And the next question, if you are fistulizing Crohn's,
Yes.
does that lead to cancer?
Well, inflammatory bowel disease is a whole different ballpark. Long-standing inflammatory bowel disease does put you at risk of colon cancer if it's involving the large bowel, right? Fistulizing disease is a very complicated issue, and that could be involving small bowel, large bowel. So it's not directly related, and that is something that you'd have to be under the care of a gastroenterologist for long-term care, to manage the fistula, to manage the Crohn's disease, and to manage the prospect of cancer down the line. So that's not a simple case of just getting screened.
Another question.
We can hear.
No,
Oh, okay, right, yes.
Of the bowel side of it. If a person at the age 15, 16 had a duodenal ulcer,
15 or 16?
yes,
Yes.
had a perforated duodenal ulcer, what are the chances of that person maybe getting anything like Crohn's disease or diverticulitis or something like that?
Well, it seems like they're completely unrelated subjects. And I don't think, unless they have underlying Crohn's and they develop an ulcer in their duodenum that perforated, that they would, have manifestation of a Crohn's disease elsewhere. But usually a perforated ulcer in this day and age has to do with bacteria, and also related probably to alcohol, marijuana use, or cigarettes, that kind of thing. So it is usually unrelated to diverticular disease, or completely unrelated. And Crohn's disease is the other disease you mentioned. You can have duodenal Crohn's where you can have a perforated ulcer, but that is, again, another rare event, and that is not related in any way.
So I just wanted to ask a question, I'll hand the mic over. Can you just tell us, because you mentioned about inflammatory bowel disease and Crohn's, are there other people who are considered high risk for colorectal cancer, sir? Other people with other diseases?
Sure. Well, we mentioned also inflammatory bowel disease, and in that group there is also ulcerative colitis, which carries a higher risk than Crohn's. So that is one. There are other groups, people with family histories, strong family histories. You have father, uncle, aunt, and there are different syndromes that we can categorize. There's the typical HNPCC, or easier Lynch syndromes, that we see people in their 30s and 40s and 50s with colon cancer, with endometrial cancer, breast cancer, and related cancer. So, and it's not just the family may have colon cancer, but you have to look for those family members with also endometrial or uterine or womb, cancers of the womb, and cancers of the ovary, and cancers of the kidney. They may all be interrelated in syndromes that we have to pay special attention to. And those people, it's a strong family predisposition, and we need to screen those family members genetically, screen them at least 10 years before the onset of the youngest patient. There are other syndromes as well that we have to look at, the FAP syndrome, which we have families, multiple families in Trinidad that carry this gene that predisposes one to cancer at a very young age, up to in their 20s. And they develop polyps throughout their colon and sometimes throughout their GI, the gastrointestinal tract from their stomach down. And those patients, once diagnosed, the family is diagnosed, we need to study the entire family tree to ensure that they don't develop cancers by age 20. So there are, and there's some other more rare conditions that we don't see as often that also carry familial risk. But those are the big ones that we have to be really vigilant about. If you see a number of people with cancers in the family, we have to really look out for the immediate relatives, because it does carry quite a high risk.
And in those relatives, instead of screening at 50, do you say screen earlier?
Yes, we say screen 10 years younger than the youngest patient. Yeah. And that is about standard. So if the youngest patient developed colon cancer at age 30, now this is for this particular group, then we say, okay, you develop cancer at age 30, my son will have colon cancer at screening at 20, and that kind of thing, so that we start earlier so as to pick them up much earlier and hence offer a potential cure. And sometimes we may even say, okay, you are such a high risk for developing colon cancer, we're going to offer to remove your entire colon for you, so as to reduce your risk. If we know that the risk is close to 100%, that you will develop colon cancer, we will offer as a child, as you go into teenage years, to remove your colon once you start developing these polyps and this FAP syndrome. Not everybody is like that, but there are certain syndromes we would say we need to do a prophylactic removal of the colon for you.
Yes, sir. Now, if you do have polyps, tell us what you should not eat.
What you should not what?
Eat.
I tell people, and they always ask the question, eat healthy. And we all know in our hearts and our minds what eating healthy is. No suffering, no oil, no grease, plenty fruits and vegetables, not too much red meat, well, not too much of any meat, right? Homegrown is better than, frozen foods. So we all know what healthy food is. And probably eating a little bit often is better than eating big meals. Exercise, keep fit, see a doctor. In the UK, they have with their screening program, they have recognized that people who have been screened for colon cancer with a scope between the ages of 55 and 64 live longer. And the scope is not a magic wand. Why that happens is because those people who have been, if your doctor tells you to go get screened and you get screened, you're likely to follow all of your other doctor's advice, meaning checking the cholesterol, eat a certain way, live a certain way, and that makes a difference over the long run. So eat healthy, right? Avoid too much fat, grease, processed foods, right?
Good afternoon, gentlemen.
Good afternoon.
We mentioned lifestyle as being one of the factors that affect us in terms of the colon cancer. We mentioned food, but what about our drinks? We tend to have a very high intake of alcohol here in Trinidad. How would that affect the colon in terms of if you are diagnosed with
If you're
cancer?
diagnosed, no impact really, if you're diagnosed.
What happens after if you should have to do, like Dr. Dan said, the resection? Would it have any effect then?
You're saying alcohol in terms of resection and the link.
Yeah.
Well, obviously, if you're alcoholic or then it will certainly affect your surgery because it means sometimes you may have liver compromise, and with liver compromise there may be increased bleeding, risk of healing, wound infections. These all go up once we have all of that. The wound healing is a big issue because the nutrition generally is, though we expect to be good in alcoholics, is actually pretty bad. And the risk of breakdown when we join them up, of the abdominal wound opening and that kind of stuff, is quite significant. In terms of alcohol, as an initiator of colon cancer, I mean, we all know that the bad things are always bad, and the smoking and the alcohol are generally, bad for us, and goes so much to say also obesity carries a risk of cancer of the colon and so on. So the healthy lifestyle is part of it, is maintaining a lower cancer profile.
Good evening, doctors. Good evening, everyone. I just have a comment to make. Is this the first session we're having like this in the South? I'm just asking.
We'll ask Dr. Chamley, who's the initiator of this session.
I lost a friend. Yes, that's why I'm here. And I just want to share a quick story. I was away. When I came back, I got a phone call. Auntie Jenny said, call her urgently, And that friend of mine was my best man in my wedding.
Mm-hmm.
And when I went to visit him, he was already gone.
Mm-hmm.
And I think he was alerted to do some testing and he refused maybe, as us men.
Mm-hmm.
So my question is, what are we, this is excellent because we're sensitizing the population, especially in South. It's unfortunate that a lot of men didn't really come out to the session this evening. We just 50-50 basically, And what could we do else to maybe sensitize our men, because we refuse to just go out there and get that testing done? And,
Yeah, well, that's a very good point, and it's well expressed. Well, like you said, get fit at 50. Simple thing, get fit, check your stools. But many of the men that I've screened have come because their wives brought them. Right? So the women here, you all have a lot of power in your hands. But all of you here, what you need to recognize, the people, well, this talk, this message needs to get out of this room. So we need for you all to let your friends, your colleagues know that here, now, this is something you had to do. Because far too often it's exactly as you described. People get sensitized to it when a friend, a colleague, a co-worker has been diagnosed. And that's when it clicks. Because everybody knows about colorectal cancer, you know, but they don't know. So it's there, but it's just not there. It's just out of reach. And so this is actually the first talk that we're giving in this series of public awareness. And we know it's sprinkling of people. We were hoping for more people to come, but we're now getting the ball rolling. And we will depend heavily on you all to get the message outside of this nice classroom here.
I guess if each one of you here tell 10 people or 10 of your friends, that would help spread the news.
And the thing is, men are afraid of colonoscopy, you know. But by and large, colonoscopy in a man is easier than a woman, easier than women, because men don't have a uterus. Men never had a hysterectomy, and that makes a difference in your passage through.
I beg to differ. I thought it was pretty.
I didn't do yours.
Hi.
Yes.
Good afternoon. I walked in a little late. I think you mentioned fecal testing,
Yes.
as well as colonoscopy. So my question is, yes, what is the recommendation for the general public if we are trying to put something in place more in the public sector? Because we touched on a topic that colonoscopy, for example, in the US I worked in, when you were saying that in the US Medicare covers the colonoscopy. In Canada, they do colonoscopies as well when they reach a certain age.
Well, Canada, they do the FIT up front.
Okay, and FIT stands for? I missed that.
FIT, okay, well, that's a very good question. Basically, there's several ways to get screened. So we're putting forth a series of things that you can do to be screened. And we're only putting forward what we know are high-quality tests. The first one is the FIT, the Get Fit at 50 initiative, where people will test their stools for blood that they cannot see. Right? That's the first thing. And that can be
what age?
Sorry?
What age?
From the age of
Yeah.
50.
Right.
And that can be widely done. It ultimately will be a test people can do at home, at the doctor's office, through a lab, in the health center, out of their pharmacy. Right? So that is the FIT test. The next test is the colonoscopy. The colonoscopy is the gold standard test because that we can find polyps, remove it, and prevent the cancer. With all the breast and prostate cancer screenings, we still cannot prevent any of those cancers. But we can do it with the colon.
I was just wondering, because it's harder to sell colonoscopy than maybe the FIT test.
It's hard to sell something that people don't even want to buy.
Well, it's
Even if you give it to them for
test
free,
to
they don't
an
want it.
extent, and people are also afraid of
course.
colonoscopy and anything.
Sure, I mean, that's natural, and I don't mind if people are afraid of it. I mean, that's all part of the process. People must recognize that for every intervention, there's a risk.
And there's one other, I know the flexible sigmoidoscopy is another one that is useful in that most of the tumors now are picked up on the left side, and you can do that as another screening
Yes.
tool every 5 years.
Yes.
And but it will miss about 30% of tumors if you're using that as a sole screening tool, and that together with the FIT is probably also not a bad combination if you know.
Yeah. In the UK, they said, listen, there's no way in hell we could screen all our people with colonoscopy. We just can't do that. But we'll train nurses and we'll do the flexible sigmoidoscopy. Now, the colonoscopy examines the full colon from the anus all the way around to your appendix. The flexible sigmoidoscopy comes up to here. And most of your cancers are down here. And the information from those studies are about 15, going on to, not quite 20, but 15 years. And the evidence is quite clear that people who've been screened that way, the outcome is very good in terms of cancer pickup rates, cancer and stage of diagnosis. In fact, the Canadians are now, some provinces of Canada are adopting the flexible sigmoidoscopy and using it for 10 years as part of their screening regime. Now, our guidelines that we're proposing, and it's a work in progress, would be the FITD stool testing, the colonoscopy, the gold standard, and the flexible sigmoidoscopy. And why we've included it in those set of tests, because the Trinidad and Tobago Cancer Society had a distinct interest in pursuing the flexible sigmoidoscopy clinic and having physicians who are interested learn to provide that. Well, that would be doctors, learning from doctors, mentoring.
Can either of you say something about virtual colonoscopy?
Philip?
Virtual colonoscopy is essentially a CT colography or a colonoscopy of the using CAT scan. Now, it gives reasonably good pictures of the colon, but it is for those patients who may not be able to tolerate a colonoscopy very well. The cost to do virtual colonoscopy as a screening tool is going to be prohibitive, as well as the second thing is that it does not allow you to do a biopsy at the same time. And then the third thing is radiation. You're exposed to significant amounts of radiation. So it is a tool that is useful, but there's a role for it. And I don't think it can be used as a screening for the general public, but there are specific rules for that. Just like other things, like a pill cam, for instance, that is useful for some issues, but not, because there's a pill that you can swallow that has a camera on it, and you can look through the bowel, but that is not indicated because the cost is going to be too, difficult to make it worthwhile.
Yeah, the thing is with these high quality testing, be it the stool testing, the colonoscopy, or flexible sigmoidoscopy, as good as those tests are, once they're done properly, only 3 out of 10 people are going to do it. So a lot of work has been done in finding other tests to get more people to do it. And that's where the virtual colonoscopies come in, the pill cam. But we would not recommend those as high quality tests at this point. The thing is, if someone is motivated to get tested, if you're going to do a pill cam, if you want to do a virtual, you still have to take a purge. And for most people, the purge is the worst part of it, right? And for me, if I'm going to take a purge, I want to get the most out of that purge. And there's only one test to do if you're going to take a purge. And you want to get the most out of that's colonoscopy. Because you do any of those tests, and you find something, guess what? What do you think you have to do? Right, a next purge.
Any other questions? Any other questions? So I'm Stacey. I'm one of the representatives from the Medical Association. It is my pleasure to do a vote of thanks. I'm being told to move up a little bit. I want to thank all of you, first of all, for coming out this evening. And I'm sorry about your friend, but if the only thing that he taught you was to come and figure out to get tested for yourself, then I'm glad you came. And just as what Dr. Trinidad is saying, if the 23 of us here go and tell 10 extra people, that's 230 people we would have screened. And if one person we could pick up a little earlier and we do something for that one person, then to me this was worth it. So thank you all for giving up. Yes, sir. I'm going to work on that. How's that? Is that okay? I'll tell you, it's not for want of trying, because the 3 gentlemen you see here are wonderfully busy and really, I'm very appreciative. They're all 3 UE lecturers. So on the University of the West Indies has supported us in this. And Dr. Trinidad, I'm reliably informed, is off of his sick bed. His wife has his chicken soup waiting for him at home. So I want to thank Dr. Trinidad for being an excellent moderator. Dr. Faisal Daniel just finished seeing a patient at 5:45 to race across here because Dr. Bascom, who was on his way down, got stuck in traffic at the Nagar site. And he literally 2 minutes before stepped in on his behalf. And so I want to thank Dr. Faisal Daniel for stepping in. so wonderfully. And Dr. Dilip Dan, who is in his red socks that are matching his red shirt and just looks splendiferous, is on his way to do his obligation at the Diwali Nagar site opening. And he is here and he's saying, Stacey, please get me out in time because I can't be late for that as well. So I want to thank all three gentlemen for encouraging us and for giving your knowledge and of your time this afternoon. I want to also thank UTT for providing us with this venue. UTT stepped forward and stepped up and didn't blink when I said, help, help, we need a venue to have people, and of course they marvelously said, absolutely, and not just this venue, but we're going to have a similar one in Port of Spain and one in Tobago. So thank you to UTT for all their support. And last but not least, but we have the Trinidad and Tobago Cancer Society, whom we're hoping to help us with advertisement of similar things like this and to get the word out there. So again, on behalf of all of us on this stage, to all of you not on the stage, thank you for coming out. Thank you for those of you who've taken your time to come and teach us tonight, and I wish you all a safe journey home.